I'm starting my presentation on approach to a patient with chest pain. Chest pain is the most common reason for which patients present for medical attention, and chest discomfort are of about 3 categories. Number 1, myocardial ischemia and other cardiopulmonary causes and non-cardiopulmonary causes. Chest pain also categorized in central chest pain and peripheral chest pain. Central chest pain include cardiac cause, aortic cause, esophageal cause, pulmonary embolism, mediastinal, and anxiety disorder. Cardiac cause includes myocardial ischemia or angina, myocardial infarction, myocarditis, pericarditis, mitral valve prolapse syndrome. Aortic cause includes aortic dissection and aortic aneurysm. Esophageal cause includes esophagitis, esophageal spasm, gastroesophageal reflux disease, Mallory-Weiss syndrome, esophageal perforation. Pulmonary embolism, mediastinal cause include malignancy, anxiety, or emotion. Peripheral chest pain includes lung cause, pleura, musculoskeletal, neurological, and gastrointestinal tract cause. Lung and pleura include pulmonary infection, pneumonia, pneumothorax, pleuritis. Musculoskeletal cause includes osteochondritis or Pitt-Synd syndrome, rib fracture or injury, acute vertebral fracture, intercostal muscle injury, epidemic myalgia, and osteoarthritis. Neurological cause includes prolapsed intervertebral disc, herpes zoster, and thoracic outlet syndrome. The causes of chest discomfort according to their frequency, the most common causes are gastrointestinal, which is 42%, ischemic heart disease accounts for 31%, chest wall syndrome accounts for 28%, pericarditis 4%, pleuritis 22%, pulmonary embolism 2%, lung cancer 1.5%, aortic aneurysm 1%, aortic stenosis and herpes zoster 1%. The assessment of chest pain, we can assess it by the mnemonic PQRSG, P for provocating and or palliating, which includes, does anything cause the pain get worse or better? Quality, how does it feel? Sharp, dull, or burning? Region, where is it? Does the pain refer anywhere, or can it be pointed to? As for severity, is it mild? The patient is in distress. How do they rate the pain? And time, how long has the pain has been going for? Minutes, hours, days, or weeks? How quickly did it come on? This is the consideration in the assessment of the patient with chest discomfort. Could the chest discomfort be due to an acute, potentially life-threatening condition that warrant urgent evaluation and management, which includes unstable ischemic heart disease, aortic dissection, pneumothorax, pulmonary embolism? If these are not, could the discomfort be due to chronic condition likely to lead to serious complications like stable angina, aortic stenosis, and pulmonary hypertension? If not, could the discomfort be due to an acute condition that warrant specific treatment like pericarditis, pneumonia or pleuritis, and herpes zoster? If not, could the discomfort be due to another treatable chronic condition like esophageal reflux, esophageal spasm, peptic ulcer disease, gallbladder disease, and other gastrointestinal conditions? Cervical disc disease, arthritis of the shoulder or spine, osteochondritis, other musculoskeletal disorder, and anxiety state. This is the difference between the ischemic cardiac chest pain and the non-cardiac chest pain. Where is the location? The ischemic cardiac chest pain is central and diffuse, which is radiates to the jaw, neck, shoulder, or arm, occasionally to the back, and which is tight and squeezing talking character, and precipitated by exertion and or emotion, and relieving factor is rest, quick response to nitrate, and associated with breathlessness. But non-cardiac chest pain is peripheral and localized. There is no radiation or other side of the central ischemic chest pain radiation. Characterized is sharp, stabbing, or catching. Precipitation is spontaneous, not related to exertion, and provoked by posture, respiration, or palpitation. Relieving factor, not relieved by rest, slow or no response to nitrate. An associated feature is respiratory, gastrointestinal, locomotor, or psychological. This is the picture of typical ischemic cardiac pain. It shows the likelihood ratio of acute MI. This is the radiation to the right arm or shoulder, increased likelihood of acute MI. Radiation of both arm or shoulder associated with exertion. Radiation to the left arm associated with diaphoresis associated with nausea or vomiting, worse than severe angina or similar to previous MI, and described as pressure. It is graded as 0 to 5, and it shows the likelihood ratio of increased acute MI. And this picture shows the decreased likelihood of acute MI. These are inframammary location, reproducible with palpation, described as sharp, described as positional, and described as pleuritic. Key to distinguish cardiac causes. The myocardial ischemia, which includes stable angina, unstable angina, and myocardial infarction. Stable angina pain is retroesternal and precipitated by exertion or cold or stress. Its duration 2 to 10 minutes and improves with rest. But unstable angina is also retroesternal and increasing pattern or does not improve with at rest, and duration is more than 10 minutes. Myocardial infarction, it is also retroesternal, constrictive severe pain, usually more than 30 minutes, and that require lab confirmation like ECG change or raised troponin I. Pericarditis, which is pleuritic in nature, sharp retroesternal or towards the cardiac apex, may radiate to left shoulder. Worse in lying position may be relieved by sitting up and leaning forward. And clinically, pericardial rupture may be found. Mitral valve prolapse, here transient pain, mild systolic click, and common in female. Aortic dissection, this is substernal tearing pain, radiates to the back between the shoulder blade. And pulse deficit or aortic valve insufficiency. Aortic aneurysm, deep steady pain located at the site of pressure on musculoskeletal system, may have cough, dysphagia, other symptoms of local compression. GIT cause includes esophageal spasm. By clinical features, there may be dysphagia, regurgitation, ECG will be normal, relieved with nitroglycerin. Cholecystitis, here positive Murphy's sign. Peptic ulcer disease, the pain is epigastric, burning in nature, associated with meal. There may be periodicity and history of NSAIDs taking. Gastroesophageal reflux disease, pain is half hours postprandial and burning in sensation, relieved by antacids. These are the respiratory causes, includes pulmonary embolism, where there is sudden onset of pleuritic chest pain and may manifest as heaviness with massive embolism. Pleuritis, pain on the respiration, fever, rapid shallow breathing. In pneumothorax, sudden onset pleuritic dyspnea, hyperresonance on auscultation, and decreased breath sound on the side of pneumothorax. Pneumonia, pain is pleuritic in nature, associated with fever and freckles. Musculoskeletal causes includes osteochondritis, where the external pain worsened by chest movement, osteochondral junction sensitive to palpation, and relieved by non-steroidal anti-inflammatory drugs or steroid injection. Cervical radiculitis, where there is constant pain on or shooting pain, may be dermatomal distribution, worsened by neck motion. Trauma or strain, usually constant, aching localized to area of strain, reproduced by movement or palpation. Epidemic myalgia are basically a myositis characterized by paroxysm of stabbing pain in the muscle of the chest and abdomen, seen mainly in older children and young adults, sometimes in epidemic form, and it is caused principally by Coxsackie B virus. Panic disorder, which is dull constricting ache with shortness of breath, lightheadedness, recent unusual stress, and recurrent episode in healthy individual. Diagnostic test with target. ECG, there may be myocardial infarction and pericarditis, where the ECG tells ST elevation or depression may be found, pathological QF, and T inversion. Chest X-ray, which includes aortic dissection and aortic aneurysm. Upper GI endoscopy, target is to exclude JARC and ulceration. Ultrasonography of abdomen, if you suspect cholecystitis or gallstone. Chest CT or MRI, aortic disease and pulmonary embolism. Esophageal motility for esophageal spasm. Stress test if angina, echo, pericardial fluid and aortic dissection. And transesophageal echo in aortic dissection. The summary of today's presentation. If a patient comes with chest pain, we assess the patient and define the risk factors, identify whether the pain is central or peripheral, either cardiac origin or not, do a bedside ECG, and further evaluation of the patient for according to suspicion. Thank you, everyone.